Good morning, everyone. This is Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination here at the Task Force for Global Health. And I welcome you to the webinar series where we're having conversations with authors of reports in the Innovations in Hepatitis Elimination series for Clinical Liver Disease Journal, one of the journals of the American Association for the Study of Liver Disease. And we're very, very happy to have a conversation today with Dr. Barbara Cave, who's an assistant professor of medicine at the University of Louisville School of Medicine in Kentucky, where she'll be talking about an innovative educational program. You know, one of the key interventions to successfully reach goals for hepatitis C elimination is how to integrate hepatitis C testing, care, and treatment into primary care settings so that these interventions can be as widely available as possible. Now, fortunately, because of the development of highly curative all-oral regimens that have an excellent safety profile and only require 8 to 12 weeks of therapy, you really have an excellent opportunity to make that integration into primary care happen, but you have to develop some strategies to make it happen. And I'm very happy that Barbara's here today to describe her educational program and the results that actually show an excellent way forward through clinical education. So welcome, Barbara.
Thank you so much. I'm very happy to be here.
Why don't you if you could just give us a little bit of an overview about the educational program, you know, sort of why it started and how you set about setting it up, and then some of the outcomes from it.
Sure. Well, first of all, I want to thank everybody that's worked on camp with me. The Kentucky Hepatitis Academic Mentorship Program certainly did not happen in a vacuum, and it took a compilation of things happening in Kentucky and with our Medicaids, as well as a group of minds coming together to see camp successfully launch. If you recall, back in 2015, there was a massive HIV Hep C outbreak in Austin, Indiana, which is in Scott County, which is just 40 miles away from Louisville. About that same time, we were recognizing increased cases of infants born to women with hepatitis C and began developing a reporting system for pregnant women and those children born to those mothers, as well as children under 5. And then flash forward to 2016-2017, Medicaid was reducing their restrictions on treatment. Sobriety restrictions were starting to go away, fibrosis restrictions were starting to be reduced, but at the same time, with the opioid epidemic taking off, we were having more and more patients coming in, younger patients, with viral hepatitis C infections. So we had a compilation of everything happening all at once here in Kentucky, to the point where we recognized we needed to help the specialists reach more people. And by doing that, it wasn't going to take more specialists. There's already a limited number of specialists here, but we needed to engage our primary care providers, and along with them, women's health providers and our addiction specialists, to come up with a team to help address this burgeoning epidemics, the dual epidemics of opioid addiction and the hepatitis C epidemic that was taking place. So in about February of 2018, Kathy Sanders, who had been to a training, I think it was in North Carolina, came back with some ideas on what eventually became the camp model, where the experts would share specialist knowledge with interested primary care providers to go ahead and learn how to screen, diagnose, treat, and cure or refer patients with hepatitis C. And it didn't take much effort to convince primary care providers to participate in the program because they were already asking for it. There are a number of places throughout Kentucky that don't have any specialists, never mind an infectious disease specialist or a gastroenterologist capable of treating hepatitis C. So we had pockets of Kentucky inundated with viral hepatitis, and nobody to take care of them, but there were providers, primary care providers, interested in helping these patients. So by developing the camp model, we were able to help meet a need and bring training and education and support, long-term support and mentorship to primary care providers to learn how to do it, but also support them through some of the complicated cases.
Excellent. So how did you get the primary care providers you even get interested enough to begin to take the training. And I always think that's that first step is really a big one sometimes.
Right. So there was some doubt initially. When we first thought about camp, we thought it would be maybe a one and done kind of thing, or a small group that we would follow for a period of time. The Kentucky Rural Health Association deserves to be credit for advertising the camp program in the first place. We looked at where the need was greatest, which is in our rural counties. So we did our very first camp program in Hazard, Kentucky, which is one of the #1 hotspots on the planet, certainly in Kentucky for hepatitis C, or at least it was at the time. So we targeted the primary care providers there and set up the first in-person camp for August 2018 to be the day after. I'm sorry, it wasn't Hazard, it was in Lexington. But it was the day after the statewide hepatitis conference that had taken place. And so recruiting our first group of participants was actually not that difficult because it was so close to that conference where we already had a group of interested providers. And our first cohort was about 30 people, but within a week of that first program, Hazard was already asking for us to bring that program over. So very quickly word of mouth spread that there was the camp program, that we would go where the areas of need are, bring the program, bring the experts, bring the training, and it could be done in a live session. So within our first year, when we thought we would just have one cohort, we ended up having, I think it was 5 groups of people come through the training, and very quickly we reached over 100 providers, and by our second year we trained over 190 primary care, addiction care, and women's health providers how to screen, diagnose, treat hepatitis C. And it was all done with word of mouth and the support of the Kentucky Rural Health Association.
It's amazing. Do you have any sense, I know I believe in the article you said that none of these providers had prescribed hepatitis C treatment before they received training in the program. Is that correct?
That's correct. So Kentucky Medicaid at the time still had prescriber restrictions, but they could prescribe in consultation with a hepatologist, infectious disease specialist, or gastroenterologist. So the way we designed camp, we put in a consultation mechanism that we worked with our Medicaid providers to basically get their approval. We designed the camp consultation form to largely mirror the typical prior authorization form for viral hepatitis C treatments. And we said, if we do this consultation form and have this information on it, would you accept that as documentation of consultation with a specialist and allow this primary care provider to go on and prescribe and approve the treatment that they're wanting for their patient? And they worked with us and agreed, and that's how we were able to overcome the prescriber type barrier here in the state. And I'm really happy to say, as of a couple of months ago, even the prescriber type restriction has now gone away. So Kentucky really does not have any prescribing barriers at this point. It's been a constant evolution since 2015, and we're very lucky to be in the position that we're in, because we are still leading in viral hepatitis, but we are certainly starting to make long forward strides in battling the epidemic.
Yeah. Well, you certainly have. I mean, I think I've been fortunate to visit Kentucky several times, and to go to the statewide hepatitis meeting and visit Hazard on several occasions. And I think it's really incredible all the different responses that the state of Kentucky has put in place in response to this epidemic in the state, both at the state health department level as well as among clinicians and community-based organizations. It's really been, and I think they've been very effective, as this camp program is only a case in point. Any idea about how many total patients received treatment from these providers that were trained? I know that's sometimes hard to track, but even just an estimate would be informative.
Yeah, so we definitely have an idea based on the number of consultation forms that have come in through our system. Currently we are using an electronic SFAX system. It's a HIPAA-compliant, web-based tool, and so we're able to count the total number of consultations that come in. As of last week, it was well over 1,100, and if you assume a one-to-one consultation equals a prescription and a treatment, it's on the order of 1,100. But I'm sure there's some natural drop-off, people that maybe were approved that never actually picked up their medication, and that kind of stuff even happens here in the specialist's office. But it's been quite a few. So the camp program now is 2 years and 2 months old, and we've impacted over 1,100 participants but there could be more. There might be consultations that never even came in, given that the prescriber restrictions have now gone away. Some of our camp scholars that have been in the program longer may feel completely confident and comfortable prescribing on their own and are no longer sending in the consultations. So, hard to say, but the best estimate is 1,100.
I know they did the consultations, and you have a very nice form that was completed that I think could be a nice tool for other programs to use. And so I really encourage people to go to the journal and look at that form that was the basis of this teleconsultation. But you have a sense of how the types of issues that the primary care physicians or clinicians were facing and how those changed as they got more experienced in training. I know that in other
so it seems the biggest challenge, which
go ahead.
I'm sorry, you jumped out a little bit on me. But the biggest challenge, it seems, initially when a provider is new to the program is really fibrosis staging. And if you think about it, we've come a long way in recent years in assessing fibrosis. We've got this shift from ultrasounds and liver biopsies to our non-invasive markers, and things like vibration-controlled transient elastography has increasing availability, as do the proprietary lab tests like a FibroTest or FibroSure. So there's multiple modalities available now, so helping the primary care providers and new treaters understand fibrosis assessment non-invasively, and when they need to move from non-invasive to a liver biopsy seems to be one of the biggest challenges early on. But after some experience, after seeing several examples, after really getting their feet wet, so to speak, they begin to understand fibrosis assessment and are able to do that easily, quickly, with more accuracy, and are able to prescribe more comfortably. The medications themselves do not seem to be much of a challenge. Drug-drug interactions, we provide a number of resources to be able to address those and work with those. That doesn't seem to be much of an issue. And then we have high approval rates with our Medicaids because the restrictions are not nearly what they are in other states, and certainly are not nearly as cumbersome as they were in the past. So I would have to say fibrosis assessment seems to be the biggest challenge for our new treaters.
Excellent. So what's been the response from patients? Do you ever get any feedback from patients to know how maybe the camp is invisible to them, or do they know about this partnership that's making this training and therefore the treatment possible?
So patients do have an awareness that camp is there. They're on our consultation form. Some offices wanted like a HIPAA type of agreement where the primary care practice will have the patient sign so that they know that they're releasing some of their health information to us. Now, with this being an educational program, it doesn't necessarily fall strictly under HIPAA, but some providers are wanting to do that, and so we happily do that. I don't necessarily interact directly with a patient, with the exception of maybe a more complicated patient where they still can't get to a specialist for one reason or another. We may do telehealth with them in parallel with their primary care provider that's doing the actual treatment. So there is some interaction with patients, but that's more of the exception, not the rule. But patients are aware that their provider is involved in the camp program because they see some of the camp documentation and may have signed off on the agreement to send their records over to us.
And then the other key stakeholder in this would be insurers and payers. And you mentioned how some of the restrictions have been removed, which were the reason camp got started to begin with. But just over that course, did the Medicaid program may have always been aware of it, but even private insurers, I was just curious as to the response to health systems and insurers to the program.
Sure. So overwhelmingly positive. Again, once if you can complete a prior authorization form, that patient's very likely meeting all the criteria that the plan would have in place. So we try and not buck the system too much, because generally the system's working for the patient at this point, at least here in Kentucky. It is a rare instance where we'll see a denial for a treatment, and that's usually just because of a formulary issue and nothing else, and that includes with the private insurers. But of course, Kentucky is primarily a Medicaid state or a Medicare state. We're not a wealthy state, and we did do Medicaid expansion, so the overwhelming majority of our patients are treated on Medicaid and Medicaid dollars. But even with the private insurers, we still see a lot of success in getting those patients treated through the model.
Mm-hmm. I imagine when you first started, it was heavily focused on adults. Has it now beginning to recognize that some children are being found to have hepatitis C, and so do you have a pediatric component as well?
So there are multiple components to camp, and that does include a session on pediatric and adolescents with hepatitis C, as well as helping to understand the care of a pregnant woman with hepatitis C. But as far as consultations coming through, I have yet to see one for a child, although our providers are trained to screen, diagnose, and recognize a pediatric infection. They can move forward with treatment of a pediatric patient if they have them. The medications are FDA approved. We would support them and help teach them, but so far we have not seen any requests for treatment of a pediatric patient. Maybe a 17, 18-year-old, but generally speaking, the younger children, we've not seen anybody come through camp yet. And that could be a reflection of the primary care providers that we're seeing are maybe not family care and maybe do focus just on adults. But it could just be that these children haven't been identified yet in these family care offices. Hopefully, over time, we'll start to see them, or their providers will recognize them and go ahead and move them forward and get them treated as well, because the mechanisms are in place to allow that to happen.
Okay. The other thing I noticed, in reviewing the report, reading the report, is there's not a lot of description about sort of the care algorithm that particular care provider receiving the training is using. So I'm interested, because we're very much all about simplifying, how simple can we become in managing hepatitis C. So I'm very interested in what was the element of the training in that regard, and how have you seen the care models change over time in Kentucky?
So thank you for that question. So our recommendations have always mirrored the AASLD recommendations for on-treatment monitoring, as well as the package inserts, which, as you know, with our most modern direct-acting antivirals, there's no recommendation for on-treatment monitoring. So we've always followed the AASLD guidelines and basically used that as a framework for what we teach our participants. And with the most recent guidelines and the very, very simplified treatment, for the first time just yesterday, we did a Camp 1 session yesterday remotely, the instruction was no on-treatment monitoring, you don't need to do labs until SVR 12. And it's just like, wow, that is awesome. I hope that it's not terrifying to our new treaters as well, because there's some natural nervousness, I think, and they have not seen the data, they've not seen all these patients to have the experience of knowing just how effective these medications are, how gentle they are, how quickly they work, how quickly you can see normalization in liver enzymes. It takes such a short period of time, but they're not going to have that experience because the recommendations were like, yeah, you don't have to check labs until SVR 12. So I'll be very curious to see how they feel about that, what they actually do. We don't discourage them from doing extra lab monitoring if they feel that it's in the patient's best interest or in their interest for learning purposes or otherwise. We don't discourage more frequent lab monitoring, but we make note that it's not specifically recommended, that just the SVR 12 is all that's needed. Versus 2 years ago, when we first started, we did have a treatment or on-treatment recommendation, maybe check at week 4, check at SVR 12, and check at end of treatment. It's nice that these simplified algorithms are in place. I think it reduces a lot of burden, not just on the patient but the provider as well, and also speaks to the safety and efficacy of our modern treatments. It's really refreshing.
For those on the call, if you have any questions for Barbara, just place them in the Q&A box there on the upper left of your screen. One or two other questions for me. Has the type of provider changed? I mean, I'm very, one of the populations that can pose challenges for treatment are people who have a recent history of injection drug use or are in drug treatment for their injection drug use. Is that part of the sort of the camp trainees or scholars, as you call them?
Yes, so initially we were a little more narrow-minded and we're thinking about primary care providers exclusively, but it didn't take us long to wake up and realize that there's plenty of opportunity for other avenues of care, and that includes people working with patients that have substance use disorder and addiction care providers, and we have had multiple addiction care providers come through as well, but also there's more primary care providers that are also assuming the role of addiction care providers, so it's kind of a nice little nesting of services in some of these primary care provider areas, which is absolutely critical. It's a critical need to address, especially in rural areas that are so inundated with injection drug use, like rural areas of Kentucky. I'm really glad to see everything coalescing and come together. I'm really proud to see some of these primary care providers taking ownership of the multiple, what used to be deemed specialties, taking ownership of that. But yes, we do have addiction care providers, and some OBGYN women's health providers have come through our program as well.
Very good. We're in the midst of a pandemic, COVID-19. Kentucky's no exception about having to deal with COVID-19, and then the response to it, where we've done, through social distancing recommendations, a lot of routine health care has had to change in response to that. So I'm curious as to how camp has been changed over the course of the response to COVID-19.
Well, when we first started the epidemic back in February, March, we initially canceled several of the Camp 1 sessions that we'd had planned for April, May, I think even into June. But then as we recognized that the pandemic is not going to be short or ending anytime soon, we decided that we needed to move ahead and adapt and get this thing going virtually. So we did a Camp 2 session via Zoom. I believe it was the end of August. It could have been September. My dates all kind of blur together at this point because we've been virtual long enough. We went ahead and did a Camp 2 session, and we had polled our Camp 1 participants before we went on to schedule it to see would they prefer an all-day format. Camp 2 session is a more intensive or advanced learning session for people that have been doing camp for several months already, so they have some experience and have less of a like a narrow focus. They're seeing more of the gray zone and have a better understanding of fibrosis assessment and the treatments and some of the particular clinical scenarios that can come up. So we asked them, would they prefer to do another all-day 6-hour-long session, or would they rather break that up into several segments, in which case would it be 2 segments or 3? Ultimately, what we ended up doing was 2-hour-long sessions over 3 weeks on consecutive Tuesdays. We had excellent attendance. There was excellent interaction with participants as well. There was great case discussions that went on with that. And then just yesterday, we did our first Camp 1 session using Zoom. That we did, we also split that one up. Camp 1 session's about 8 to 9 hours of content. That's a bit much for sitting in front of a computer one day, I think. So what we did was we decided to do 2 half days. So we went from about 8 in the morning until 1 o'clock yesterday, and we'll do that again next Monday for another 5 to 6 hour session to get all the educational hours in. I will tell you, yesterday's session had 54 participants. I can't tell you exactly how many were providers versus some of our support personnel. But definitely a lot of participation, a lot of questions being asked in the chat, a lot of participation with people turning on their video and their microphone and asking questions of the speaker. I was really happy to see that the virtual format really didn't seem to impede people's ability or willingness to participate and engage with the speakers, because at the end of the day, we really want to hit home with our scholars that the faculty are real people, happy to address questions. There's no question that's off limits. We want people to have a thorough understanding of the content and be excited about working with the patients that they're wanting to treat and cure. And so making sure that they know that the conversation line is expected to be open, even though we're remote and far away and we didn't get to meet in person, that it still facilitates communication. I think was really a pleasant surprise, and I'm looking forward to doing our second half of the Camp 1 session next Monday, and hopefully we still see all 54 participants once again. I hope that there's no attrition with these long sessions.
Yeah, that's great. Great adaptability. I guess my last question is, this has been going on for a while now. Do you expect it? Is there sustainability is always an issue when these innovative programs? Is the program going along for the foreseeable future? And then secondly, what has been the interest of some other states or some other programs even within Kentucky that would like to adopt this model or use it for the populations they're trying to serve as for hepatitis C treatment?
We definitely have short to intermediate term sustainability. Long term it remains to be seen. But right now we are mostly sponsored by industry, and we're looking to, now that we have data, looking to do some grants, similar to how Project ECHO would have gotten started, eventually end up with grant funding or programmatic funding for long-term sustainability. The second part of your question I've already forgotten. I got so excited talking about sustainability. Oh, U.S. HAMP. Okay, so we have begun to adapt the model to what we're calling United States Hepatitis Academic Mentorship Program. The framework for that has been built and discussed. We have prepared our one-page informational sheets, so to speak, and we are starting to share those. We are also getting multiple asks about camp. Multiple states have approached the organizers, which includes myself as well as all the authors on the article. And we have already expanded to West Virginia. West Virginia started their program several months ago, and they've already got more than 50 patients onto treatment. In fact, just in the last couple of weeks, they've got their first patients already achieving cure. So that's fantastic to see. We've had some discussions with Michigan. Michigan's going to be more of a challenge because they still have quite a few Medicaid restrictions or provider prescriber type restrictions in place, but we'll be able to work through that. The U.S. HAMP model is a framework. It's not the exact play-by-play manual because we recognize each state is different. Each state has a different set of rules. Each state has a different level of infection, and so it's an adaptable model. The Kentucky Rural Health Association is hoping to have something posted for larger dissemination here in the next few weeks. I can tell you with the U.S. HAMP model, we are moving from the electronic SFAX format into a REDCap database format for the consultation. Not only is that going to make creating these registries and monitoring the registries and data analysis easier, it allows us to have multiple states where each state's going to own their own data and manage their own data, but it gives us a chance to have some crosstalk and additional communication beyond what we're able to do at the public health department level at each state. So that's exciting to see.
Absolutely. Well, congratulations on a job well done in developing this program. You're really helping hepatitis elimination become a reality and really helping at least 1,100 people get cured for hepatitis C, it appears, in the state of Kentucky in just 2 years. So a great scale up in treatment. So congratulations and thank you.
Thank you very much. It's been a pleasure talking to you.
Great seeing you. Yep. Look forward to other opportunities to work with you in the future. Thanks again for visiting with us today. Please go and read Barbara's report. Contact her if you want more information. Please continue to follow the Global Hepatitis Elimination Coalition at globalhep.org. Thank you very much.